Hello, fellow sonographers. I'm Mike Miles, and I'm doing this presentation on pulmonary embolism and the use of echocardiography in the diagnosis of pulmonary embolism. PEs, as they are referred to, does not stand for pericardial effusion, pulmonary edema, but in fact, pulmonary embolism is typically the way we express a PE. The objective today is to define and classify PEs and the role of echo in finding PEs. The importance of this is the fact that PEs have become very common and they are sometimes fatal. The overall incidence of PE is approximately 112 cases per 1,000, or 100,000, excuse me. Now, I've found this to be true in several resources that I've been using, so this seems to be a common denominator. Typically, males are greater than females in their incidence, and this does increase with age. Death from PE account for approximately 100,000 deaths per year just here in the United States, which you may have found by the CDC's most recent estimation is much greater than the degree of fatality in the coronavirus, but that can be debated. As far as the definition and the nomenclature, pulmonary embolism refers to the obstruction of the pulmonary artery or one of its branches by a material such as thrombus, tumor, air, or fat that has probably originated somewhere else in the body. PE can be classified according to the presence or absence of hemodynamic stability, the temporal pattern of the presentation, the anatomic location, which can be a saddle, lobar, segmental, or subsegmental. A saddle embolus is found between the branches of the pulmonary artery, which generally will lay across it if it's seen in echo, which is actually kind of rare. And then the lobar and segment and subsegmental sections of the lungs. And then there's the presence or absence of the symptoms. Not going into the classification, but location with regard to echo anatomically is the saddle embolus, which is right there at the split of the pulmonary branches. For the diagnosis, there is chest x-ray, which is classic focal allogemia is seldom seen. ECG, it's abnormal in 80%, but not specific and not diagnostic. Traditional pulmonary angiography has been the gold standard, but it is invasive and it's expensive. VQ scans, they're safe and available, but unfortunately 35% of the cases are considered non-diagnostic. CT of the pulmonary artery, it's the most common, it's the most available, it's the most rapid and cost-effective, and it's highly accurate. Transthoracic echocardiography is used, but is not going to be the best way to find pulmonary embolism. However, in its findings, with direct visualization of the thromboemboli in the right heart and the PA, Generally, we're going to find RV dilatation. We're going to find RV dysfunction. It could be normal or it could be hyperdynamic in the LV. There may be some septal flattening, and there may be some PA dilatation. The findings for PE and acute PE is usually an unusual degree of TR or PR, or increased PA pressure, McConnell sign, the 60-60 sign, or RVOT mid-systolic notching. McConnell sign and 60-60 sign we'll talk about a little bit later. With regard to TAPSE, that's a method that we use. There's the isovolumic contraction time, and there's measurements on the end diastolic area, and there's a calculation for that. We'll talk about the McConnell sign a little bit later, but the 60-60 sign refers to the coexistence of a truncated right ventricular outflow tract acceleration time of less than 60 milliseconds with a pulmonary arterial systolic pressure of less than 60 millimeters of mercury, but greater than 30. With regard to the mid-systolic notching, I've got a diagram which shows what that looks like. As you can see, the mid-systolic notching. And the true sensitivity and specificity of the transthoracic echo in diagnosing acute PE is difficult to assess. Reported sensitivities range from 60 to 90%, and specificities from 80 to 95% and that may be overstated. Visualizations of an embolus can be considered diagnostic, but negative results must be confirmed with alternative tests such as helical CT. Now, as far as the role of TE, TE's major advantage is visualization of the proximal PA, and especially the right PA. The interatrial septum should be evaluated to rule out a PFO. Examination of the IVC and the SVC is important in an ICU setting. Although TE should not be implemented as the first-line test, it's still considered an alternative tool for patients with PE in an ICU setting. Other causes of PE seen in the right heart could be vegetations, masses, malignant or benign, or an air embolism. And I've got some diagrams, but they wouldn't be of good quality to be able to look at. But why is this important, whether there is or is not just RV dysfunction? Well, several studies have suggested that the degree of RV dysfunction can serve as a predictor of mortality. Some authors suggest that cases with RV dysfunction may benefit from aggressive therapeutic strategies, including thrombolysis. A majority of these patients had hypotension, but I'm not going into the methods dealing with PEs. That's not a purpose of this discussion. So what can happen with PEs? Well, it can be severe or worsening right ventricular dysfunction, submassive PE. Also, cardiopulmonary arrest due to a PE. There can be large perfusion defects from them, or free-floating right atrial and ventricular thrombus. And then the one we all know, which is hemorrhage and stroke. Sometimes we know before the echo that a PE already exists. So the potential role of echo for evaluation of a known or suspected PE is that it does contribute to the diagnosis, and it evaluates the hemodynamic consequences. Now, CardioServe had done a study back in 2015, and they have updated it, and they found that 60 to 100,000 deaths per year in the U.S., according to the CD statistics, was pretty close to accurate. 10% of the symptomatic pulmonary emboli are fatal within 1 hour of symptoms onset. However, diagnosis can often be difficult because the presenting signs and symptoms are non-specific and often mimic other cardiac and pulmonary diseases. Interventional strategies to remove or dissolve thrombi continue to improve, but with these improvements, our ability to understand the diagnosis also needs to improve. Echocardiography can aid and provide important functional information about the right and left ventricle that cannot be ascertained from other tests. There are also different diagnoses of thrombi to keep in mind, such as tumors and myxomas. The right ventricle is not used to a lot of pressure or resistance and does a poor job at acutely responding to a sudden increase in afterload. So it's an important barometer to what's happening in the pulmonary arteries and on the left side of the heart. Now, the right ventricle in pulmonary embolus, there is an acute rise in pulmonary resistance. The pulmonary pressures do not go up acutely, and that's a common misconception that they do. The increase in the pulmonary vascular resistance results in increased RV afterload and increased RV wall tension. The RV dilates acutely and becomes dysfunctional. Reduced cardiac output leads to a reduction in LV output and ultimately hypotension. Depending on the size of the PE, it can result in right ventricular failure. So now we're going to talk about McConnell sign, which most of us have seen. McConnell sign is one of the most distinct echocardiographic findings in patient with acute pulmonary embolism. And the sudden pressure overload of the RV also causes increased wall stress. And as a result, it is left mechanically stunned. The right ventricle has a complex shape, so distribution of this stress is not uniform. There's a mid-right ventricular free wall bulging and localized ischemia of the free wall due to the increased stress. The apical section of the RV is not exposed to this stress due to its location next to the LV. So the RV apex is anatomically tethered with the apex, LV apex. And so what we're seeing is the LV is usually hyperkinetic due to tachycardia, and this pulls the RV apex along with it for a proxy contraction. So that's where you see the dip of the McConnell sign from the RV side. Now, as far as tricuspid regurgitation, remember that pulmonary resistance, not pressure, elevates during pulmonary embolism. TR velocities are not particularly high in an acute PE. Velocities usually seen between 2.5 to 3 meters per second. It may be normal for an acute PE, assuming the right heart is not accustomed to the high pressures previously. Echo is an effective way to monitor thrombolytic therapy. Within several hours after thrombolytic therapy or suction embolectomy, echo demonstrates reversal of RV size back to normal, reversal of RV dysfunction back to normal, and it can be quite dramatic. So some of the updates in echo for diagnosing pulmonary embolism, a JASE study done in 2016 analyzed the findings from 511 consecutive patients with pulmonary embolism. The study assessed the frequency of echo findings in pulmonary embolism with the following findings. RV enlargement was 27%. RV free wall hypokinesis was 27%. McConnell sign was 20%. Interventricular septal flattening was 18%. And the 60-60 sign, which we talked about, was 13%. So this article was originally written by Judith Buckland, who's an MBA registered cardiac sonographer, and this was done in December of 2015. So thank you for taking the time to listen to this presentation, my fellow sonographers, and as far as PEs go, happy hunting.